Thank you very much once again. So my second presentation after this hands-on session will be about something where 3D echocardiography has really changed the game. Tricuspid valve was almost neglected until 4 or 5 years ago. Also because with the 2D, as we will see in a moment, we have quite limited opportunities to assess the anatomy and the function. Now, also because of 3D, it has become one of the most popular valves, and there are a lot of studies around that. Also, despite a huge number of papers like this one by Nath and co-workers and Shuran and co-workers that have shown almost 20 years ago that tricuspid regurgitation is an independent predictor of patient survival, and that survival decrease with the increasing severity of tricuspid regurgitation, this was not that much evaluated by clinicians. One of the reasons is that with the 2D echocardiography, differently from the mitral valve and the aortic valve that we have seen before, the tricuspid valve is not so easily studied. Independent on the approach, transthoracic, transesophageal, and on the view that you use, usually you don't see more than 2 of the 3 leaflets of the valve. So it's quite unusual to be able to, with the 2D echocardiography, have the entire valve to be examined. And also, depending on the orientation or your view, it's quite challenging to identify exactly the leaflets that you are looking at using your 2D images. A few years ago, Karima Adezia from Chicago has proposed a sort of guideline, technical guideline on how to identify the leaflets, and showing that when you have a 4-chamber view, if you tilt your probe, and by tilting the LVOT appears you are quite anterior, so opposed to the septal leaflet you will have the anterior leaflet. If tilting you will see the coronary sinus, you are quite posterior, and this is the posterior leaflet. But this is not that easy, and it's also time consuming. And as we have seen already with the mitral valve, but much better here with the tricuspid valve, with the 2D echocardiography, what we can achieve, but it's just in a minority of cases, that you can see all 3 leaflets in one short axis views, but then what you see is that just the margin of the leaflets that are dancing into the dark of the atrium. With the 3D echocardiography, and the good news that due to the anterior position of the right heart, transthoracic, the transthoracic approach provides much better images than the transesophageal. You see the entire valve in the majority of the patients, as you can see here. Here we have the interventricular septum. Here is the mitral valve. So attached to the interventricular septum, you have the septal leaflets of the tricuspid valve. Here you have the right ventricular outflow tract. Here should be the pulmonary valve. And so this one is the anterior leaflet. And of course, this is the posterior or the mural leaflet of the tricuspid valve. And you see the detailed anatomy of all the 3 leaflets throughout the cardiac cycle. Despite the tricuspid valve is more challenging to be seen than the mitral valve because the leaflets are thin, with the transthoracic 3D echocardiography, you can see in a majority of your patients. And as we have shown with the mitral valve, you are not limited anymore to look at the valve only from the ventricular perspective, as we have seen before, but you can also rotate your data set and providing a surgical view, the view that the surgeon has when he or she opened the right atrium. And once again, if we compare the 3D volume rendered images with the anatomical specimen provided by our pathologists, you see that it's quite really similar, with the big difference that with the 3D we will look at the valve in the beating heart. I told you that with the transthoracic echocardiography we can see the valve in the majority of our patients, but we need to know how to acquire. First of all, to have a good 3D data set of the right heart, not only of the tricuspid valve, but for example also the right ventricle, is essential to have the dedicated echo bed with the lateral cutout that allows you to position the patients in a steep left lateral position, almost perpendicular to the surface of the bed, and to position the probe more laterally than the position that you have in the conventional, 4-chamber view. This will allow you to obtain a sort of a right ventricular focused view, and also don't care about the proper orientation of the view, just also foreshorten the view or go down one more, but look at the view where the leaflets are seen better. You have the best contrast. Then regulate your time gain compensation. That should be in a straight line, a little bit higher than the 50%, reduce the frame rate to the minimum if possible to obtain multi-bit acquisition, and adjust the gain in order to a little overgain your images. This is very important, because if you are overgaining when you have acquired a 3D dataset, you will always be able to reduce the gain and clean the images from the noise. But if you have the dropout artifact, you cannot compensate once they are acquired. And when you have the data set, then you can display the data set in almost infinite number of views, look at the valve from the ventricular perspective, the atrial perspective, to obtain several longitudinal views, to look also to the subvalvular apparatus or a multi-slice. Is it important from the clinical point of view, this 3D visualization of the valve? Yes, it is, and I show these cases. This case is one of the many cases that we have where the 3D really made the difference. This is a 50-year-old Caucasian man that was admitted for non-cardiac surgery. Actually, it was a cholecystectomy, and during surgery, developed atrial fibrillation with heart failure, with the clear lungs and leg edema. At the ECG, in addition to the atrial fibrillation, there was also the right bundle branch block, and during the ambulatory ECG monitoring, he developed an unsustained ventricular tachycardia run. Patient was sent for echo, and you see that he has a torrential tricuspid regurgitation with a large gap within the leaflet, quite enlarged right ventricle and right atrium. All these are the right ventricular inflow view from the past approach. We looked at the leaflet, but we were unable to see really any abnormality of the leaflets until we turned on our magic for the button. And you see here that looking at the valve from the ventricular perspective, it clearly shows that both only the septal and the posterior leaflet are really tethered, while the anterior leaflet actually is flailing. And if you perform a longitudinal cut in this direction, you actually see the flailing leaflets with the rupture cord and the tenting of the under. So we started to ask the patient, and after a while, he remembered that at the age of 15, he was caught in a tornado, smashed against the wall of his house. And also this was shown by looking at the chest X-ray, where there was a clear sign of a kneeled rib fracture. So probably what we were seeing at that moment were the end of a long clinical history of traumatic tricuspid regurgitation. And of course, this changed completely the surgical plan. No more repair of this valve that should be replaced, and this was done quite successfully. So 3D echo is really important to look at the anatomy of the valve and make the correct diagnosis, but also 3D echo, as we will see in my next presentation, is crucial to assess the function of and the size of the right ventricle. That is one of the determinant of the indication to tricuspid surgery. So having such nice images of the tricuspid valve moved us to look more and more at this valve. And the first question we had to answer is, it's actually how many leaflet has the tricuspid valve? And we found that in a number of patients, there are just 2 leaflets, one septal and one large mural. In a majority of cases are 3, but maybe also 4, and have also been described the valve with 5 or 6 leaflets. So the first message that is very important, particularly nowadays that interventional procedures are developing for this valve, is that there is a large anatomical variability of this valve, and this can only be assessed with the 3-dimensional echocardiography. Recently, Rebecca Ann, in this paper in JACC Imaging, have systematized the morphology, showing that indeed in up to more than 30% of cases, there are 4 leaflets of the valve, and particularly the type 3B with a septation of the posterior leaflet is the most frequent. Not only the leaflets, but with the 3D echocardiography, we can enlarge our view to look at the adhesion and the structures, and particularly the position of the coronary sinus and the atrioventricular groove, where is the right coronary artery, that you can see here quite nicely in this view. And you see that once again, the similarities within with the anatomical specimen is really, really impressive. And also with the 3D echocardiography, we understood many new etiologies, I would say, of tricuspid regurgitation. This is an older lady with the dilation of the ascending aorta and the aortic root that was found to have a significant tricuspid regurgitation without any detectable abnormality of the leaflets. But once again, looking at it with the 3D echocardiography, we realized that the dilated aorta that you can see in this position is compressing the tricuspid annulus that became quite deformed, like an 8 shape, and was quite elongated and shrinked in the anteroposterior dimension. This deformation of the annulus was the cause of the regurgitation, but we have never realized that this can occur before having 3D echo. And talking about the annulus, we know from the anatomy that the annulus of the tricuspid valve is a quite complex three-dimensional structure, is not rounded, and this is the main reason why a single diameter that can be taken in any two-dimensional views is not enough to describe the geometry. And also, for the same patients, it depends very much on how you acquire, because if you you see here the big differences in the diameters of the tricuspid annulus according to the orientation of the view, and most importantly, none of them was really the major distance, the major diameter that you can appreciate in this multi-slice view. With the 3D echocardiography, we can also reconstruct the annulus in order to obtain anatomically sound images without any geometrical assumptions about its shape. This has been done a few years ago together with the group of Chicago, Roberto Lang, Karima Adezia, with Denise Muraro as a first authors of this paper, where we described the normal morphology and the geometry of the tricuspid annulus using three-dimensional echocardiography. And we were able to demonstrate that none of the diameters taken in the traditional 4-chamber or 2-chamber view is actually the major diameter of the tricuspid annulus. And we have also shown that the tricuspid annulus is quite dynamic throughout the cardiac cycle, and while it shrinks during the systole, and it continues to dilate throughout the diastole, reaching its maximum at the end of the diastole. And also with not only the annulus, but with the three-dimensional echocardiography, we are also able to look at, to quantitate the extent of the tethering of the leaflets with the tenting volume of the tricuspid valve. And this can also be translated in a 3D printing reconstruction of the tricuspid valve that can be used for teaching purposes, but also to plan surgical procedures. And ability of 3D printing this valve is really important, because we don't have any reference method to quantitate. Even intra-surgical measurements are quite unreliable, because the annulus is quite pliable, and even a small traction can deform it. So we can use these models to make the measurements and compare the actual measurements of the size and compare with the measurements done on 3D echo. The ability to quantitate the annulus and the extent of the tethering of the leaflet allowed us to clarify a little better the fact that there is not a single functional tricuspid regurgitation, but there are many depending from the main mechanism. And we have identified the main mechanism in two extremes. From one end, there is the so-called atriogenic tricuspid or functional tricuspid regurgitation, where the main mechanism is the dilation of the annulus, mainly driven by the dilation of the right atrium. That it's the typical case, patient with persistent or permanent atrial fibrillation with little or no tenting of the leaflets, and the right ventricle that is not remodeled in an important way. On the other end, there is the ventricular functional tricuspid regurgitation, where the dilation and the remodeling of the right ventricle create a displacement and a reorientation of the papillary muscles, determining an important tenting of the leaflets and the consequent dilation of the annulus. Between these two extremes, there are all the other mechanism that are in between some. And indeed, this has been recently described by a review paper published by Denisa Muraro in JACE, showing that indeed in patients with atrial functional tricuspid regurgitation, there is a dilation of the annulus and a small tenting of the leaflet, as opposed to ventricular functional TR, where the annulus is not that much dilated, but there is much more tenting volume. In that review, for those of you who are interested, you can see that there is also a systematic description on the main characteristic that allows you to identify the two main mechanisms of a functional tricuspid regurgitation. And indeed that the atrium is an important determinant of the size of the tricuspid annulus has been quite recently described again by Denisa Muraro, showing that the size of the annulus goes in parallel more with the size of the atrium than the size of the ventricle, saying that in a patient with pulmonary regurgitation as a consequence of tetralogy of Fallot, where the ventricle is huge but the atrium is quite small, indeed the annulus is not that much dilated, as opposed to in patients with chronic atrial fibrillation, where the ventricle was not that much dilated, but the atrium is huge, where you find the largest annuli. And this was shown in this regression, showing that the tricuspid annulus area is much more closer related with the size of the 3D right atrium than of the 3D ventricle. And this has also justification from the anatomopathological point of view. You see that the tricuspid annulus is mainly composed of fat, only the septal part has a fibrous component, and also there are muscle fibers in it, but the muscle fibers comes from the right atrium and not from the ventricle, because those of the ventricle stops at the hinge point of the tricuspid leaflets. And this can also open other clinical consequences that I am showing with this case. This is a 61-year-old woman who have a Graves' disease that becomes thyrotoxic, and so she developed the heart failure with when she developed a high rate atrial fibrillation. The echo during that showed a torrential tricuspid regurgitation with the lack of coaptation of the leaflets due to the dilation of the annulus and also of the atrium and the ventricle. Then the patient underwent thyroidectomy, and after 1 month had a spontaneous cardioversion with maintenance of the sinus rhythm. Her clinical condition improved that much, and so she came back for an echo, and believe or not, those that was a torrential tricuspid regurgitation almost disappeared, and you see that now it's just a mild one. If you look at the comparison of the two echo that we performed before and after thyroidectomy, there is not that much change in the size of the annulus. Of course, with the sinus rhythm, the function of the right ventricle improved a little bit. There was not that much change in pulmonary systolic pressure. What changes was the volume of the right atrium that almost halved after the cardioversion in sinus rhythm, and this was associated with the reduction of the tricuspid annulus size and of the severity of the tricuspid regurgitation. This has obvious implications for treatments, because if we have patients with atrial fibrillation and we identify the atherogenic origin of tricuspid regurgitation, we should make any attempt to restore the sinus rhythm in those patients, because the tricuspid regurgitation can promptly revert. Another seminal contribution of 3D echo to understand the etiology of tricuspid regurgitation is the documentation of several cases of interference of cardiac implantable electronic devices, pacemaker, ICDs, and so on, that can have positions where they interfere with the motion of the tricuspid leaflets, determining tricuspid regurgitation. And this, it's of course important consequences because in the end, if not corrected, these patients will develop a right side heart failure. Here you see two cases. On the left, a case where the lead is correctly placed into the commissure between the septal and the posterior leaflet, not interfering with the leaflets. On the other side, you have a clear interference of the leaflet to the body of the septal leaflet that is restricted in its closure. This topic has been covered recently in JACC journals, where you can see the algorithm for the treatment. And with that, I wanted to stop here my presentation on the tricuspid valve, waiting for your questions or comments.
Thank you, Professor Badano, for the nice presentation. Колеги, някакви въпроси по отношение на първата тази презентация от втората сесия към професор Бадано? There is no question from the audience, but I am wondering about the result that you show about the patient with the atrial fibrillation and the measurement of the right atrium regarding maybe the fibrosis that is possible to be in the older ages. It's one of the causes that is changed the tricuspid valve area.
Of course, this was a demonstrative case. We have many, and we are currently performing a dedicated study to show the remodeling of the different cardiac structures during atrial fibrillation and the effects of the cardioversion. Indeed, long histories of atrial fibrillation are hard to have such a successful history because of the fibrosis of the atrium, as you can say, but relatively short-term history of atrial fibrillation, like a patient with the persistent atrial fibrillation, we have seen many patients dramatically improving their the severity of a tricuspid regurgitation after cardioversion in sinus rate. And so this is and now I have to say that atrial fibrillation is more and more recognized as an important cause of tricuspid regurgitation.
There is one question from the audience. How do you think the functional tricuspid regurgitation, which is secondary to the left heart disease, how we decide which cases need tricuspid repair in that case?
Well, that's really a big question, and there are a lot of debates just in those days on how to do that, and also different views. First of all, we don't have any strong evidence, so we don't have any trial that compares the different approach, and so here we are debating two positions. The one that I really support, that is any patient who need the addition of diuretics to control the symptoms of a right heart failure, is a patient that should be considered for tricuspid valve repair until kidney disease or liver disease can develop and further increase the risk of any surgery or interventional procedure. On the other end, there is the position that says before considering any tricuspid intervention, you should maximize your treatment, particularly diuretics and eventually also vasodilators, and to control as much as possible the symptoms to have the surgery or interventional cardiology as the last resort. There are, as I said, there are no randomized clinical trial that can provide evidence between these two options, but I still think that a patient who needs the diuretics to control the right heart failure symptoms is a patient in whom the right ventricle cannot tolerate anymore the overload provided by tricuspid regurgitation.
Thank you. Колеги, въпроси? Ако не, we are ready to continue with the second presentation, Professor Badano.
Okay, I would like to share once again the screen to move to the presentation on the right ventricle. Can you see the slides?
Yes.
Okay, so we move directly to one consideration that it's a common belief among echocardiographies that studying the right ventricle with the conventional two-dimensional echocardiography is really a challenge because of the anatomy of the peculiar and weird anatomy of the right ventricle. Is a thin-walled chamber that is just behind the sternum. It's the inflow and the outflow portion of the chamber are separate, and it's not that easy to have both of them in the same view. The shape is quite weird, asymmetrical. If you look at it from the front view, is triangular. If you look at it in the transversal view, is crescentic, wrapped around the left ventricle. But what is important is that this shape cannot resemble any known geometrical figures. So unlike the left ventricle, where we can approximate the calculation of volume with the formulas from measurements of areas and length, there is no formula that can derive the volumes of the right ventricle with the simple linear or area measurement. And not only, but this peculiar shape of the right ventricle is not constant, but it changes with the changing loading conditions. And we all know that the right ventricle is particularly sensitive to loading conditions. So with the two-dimensional echocardiography, we have a quite a limited view of the right ventricle, and with even with the most complete two-dimensional study, we have just a few longitudinal and transversal cuts, as you can see in these, and so we actually see a very limited amount of the endocardial surface and of the myocardial muscle, but the large part of the right ventricle, that is the green part, and particularly the outflow tract, are completely missed with the conventional 2D echocardiography. And also the linear measurements that we perform to provide an estimation of the size of the right ventricle are quite unreliable, since because of the crescentic shape, they depend very much more on the position, on the rotation of the probe than on the actual size of the right ventricle. Here you see a clear example. These three apical views are taken from the same data set, and the orientation of the views is shown by this yellow line, and you see that just moving the line of few degrees that corresponds to a small rotation of the probe, the basal diameter changes from 39 to 46 millimeter. And you can easily realize that if this, instead of being an exercise, is just a small rotation that may frequently occurs during different acquisition during the follow-up of the patients, you can end up with a dilation or a favorable remodeling of the right ventricle, where what it happens is just a slight changing of the orientation of your views. And also with the function of the right ventricle, we have issues. You see here an example. This young man with pulmonary hypertension coming to the echo lab for the assessment of the right ventricular function. And according to the different recommended measurements of the right ventricular function performed with conventional echocardiography, we have that with the TAPSE, the right ventricle seems quite good, normal or supernormal. If we measure the fractional area change, is mild abnormal. And if we measure the systolic velocity on the TDI of the free wall, we are at the low limits of normality. But indeed, with CMR, we realize that the EF is reduced significantly abnormal. And so also the multiparametric approach recommended by current guidelines can be quite confusing, while we can now measure the volumes and ejection fraction using three-dimensional echocardiography to provide estimates, to provide metrics of the size of the right ventricle and its function that are easily understandable also by other clinicians that cannot really understand the functional meaning of terms like TAPSE, fractional area change, RIMP, or whatever it is. But when you talk about volumes and ejection fraction, any medical doctor can easily understand. The contribution of a three-dimensional echocardiography to the assessment of the right ventricle has been recently reviewed by Denisa Muraro and Karima Adezia in JAMA Cardiology a couple of years ago, providing an overview of the important contribution of 3D echo in our understanding of the right ventricle. With the 3D echo, we can use all the different modalities of displaying the 3D dataset. We can have a multi-slice of the 3D dataset of the right ventricle, providing an anatomically oriented short axis views that goes from the most basal part here at the tricuspid valve up to the apex. And this is a phenomenal way of looking at the regional wall motion of the right ventricle to realize how it works. Like in this example of inferior myocardial infarction, you see the akinesis of the inferior wall of the right ventricle. You can use the volume rendering to look at the anatomy of the right ventricle, looking at the papillary muscles and the different parts. Or you can use the surface rendering to look at the function to make measurements of volume and ejection fraction. With the volume rendering, we have a very detailed visualization of the complex anatomy of the right ventricle with the images that really are very, very similar to the anatomical specimen provided by our pathologists. Here you have the inflow of the right ventricle, the body with the trabecular apex, and here you have the outflow with the pulmonary valve, and you see almost the same image in this 3D reconstruction. But once again, with the 3D echo, we have also the motion of the pictures, so the functional anatomy instead of just the static anatomy of the anatomy. Sorry. And then we can cut the ventricle in different ways to look at the details of its anatomy. Here we can follow the right ventricular outflow tract in the relation with the tricuspid valve, or here we see very nicely the apical trabeculated part. With the three-dimensional echocardiography, we have actual 3D acquisitions that we provide the possibility to measure volumes and function without any assumption about the shape. We can repeat this exam for limited times at the bed of the patients, and we can measure volumes and ejection fraction, and we will see in a moment that those measurements are reliable and validated. Of course, it's an echo technique, and like all the echo techniques, it's dependent on the acoustic window and patient cooperation to obtain the best of the images. But it is worth to do that, because compared with the conventional parameters like, and here I provide you an example of the most popular one, the TAPSI. This provides many more information. Here you have 3 index patients, a completely healthy subjects. On the left is a control, a patient with the volume overload of the right ventricle, severe tricuspid regurgitation, and patient with a pressure overload of the right ventricle, pulmonary arterial hypertension. And you see that the TAPSI of all 3, despite in the diseased patients, there's little down, however, are still in the normal limits. And then we have measured the volume and the ejection fraction of the same patients. That provides much more information about the pathophysiology. In the healthy subjects on the left, we have normal volumes and normal ejection fraction. In the patient with tricuspid regurgitation, of course, the volumes are enlarged, but the ejection fraction is still preserved, while in the patient with the pressure overload, the volumes are within normality, but the ejection fraction, despite the TAPSI is normal, is moderately severely depressed. And this explains the fact that the function of the right ventricle is much more complex than just the motion of the tricuspid annulus plane towards the apex of the ventricle. In many conditions, particularly in patients who underwent surgery or heart transplant, but also in many other, you have a reduced longitudinal function, but the ventricle is able to maintain its function by increasing the lateral displacement. In this case, you see that there is almost no motion in the longitudinal direction. The TAPSI is just 6 millimeters in those patients, but there is quite an active lateral displacement that is preserving the ejection fraction in this patient, that is 62%. With the 3D echo, we are able to measure the volumes and the ejection fraction, and so and those measurements are quite accurate. This is a meta-analysis that we published several years ago, showing the results of all the studies, more than 1,500 patients who underwent 3D echo and CMR almost simultaneously. And as you see that, as expected, 3D echo is just slightly underestimating the volumes of the right ventricle, but the measurements of ejection fractions are quite close to those of CMR. Nowadays, we have also user-friendly software packages that provides a semi-automatic tracing of the complex endocardial borders of the right ventricle, and in a few clicks they can provide a complete assessment of the geometry and the function of the right ventricle. However, we have also to underline the fact that no or none of those software packages can work completely automated, and this is because of the extensive trabeculation of the surface of the right ventricle that makes life tough for any sufferer. So you need manual editing in order to move the border of the endocardium identified by the sufferer to the compact part of the wall. And when it's done properly, then the accuracy in the measurements of the ejection fraction is quite high, and also for the volumes. And as you can see in these, but in many other studies confirming the same things. So being so accurate, we were also trying to identify the normal volumes and ejection fraction by 3D echo of the right ventricle. This was a large study performed together with the University Federico II El Centro Cardiologico Monzino in Milan to enroll more than 500 healthy volunteers to show that the volumes of the right ventricle are dependent on sex. Even if you normalize for the body surface area, volumes of the right ventricle are larger in men, that are the blue bar, compared to women that are the red bar. And also there is an age effect with the decreasing volumes in both sexes with the elderly process. And this is compensated by a proportional increase in the ejection fraction in order to maintain the stroke volume. So the volumes of the right ventricle depends on sex, on the body size, and on the age. And to take into account all of these three variables, we need allometric equations that should be implemented in your software package. But they are worse because when we compare the allometric equation developed with for 3D echocardiography with the similar equations that have been developed for CMR, we have ended up with, again, the confirmation that the 3D echo, that are the red sheets, are a little underestimating the volumes compared with the CMR, that are the gray sheets. But as you see, these sheets are quite parallel, so they are quite predictable. Not only accurate, but also added the clinical value. This was one of the first papers showing the added clinical value of measuring the ejection fraction of the right ventricle with the 3D echo in patients with pulmonary hypertension. You see that compared to the normal, to the conventional echo parameters of a prognosis like TAPS or fractional area change, the area under the curve depicted by 3D right ventricle ejection fraction and mid-free wall longitudinal strain is significantly higher. Recently, Elena Surkova from our lab was able to show that even in the routine population coming to the echo lab with the various cardiovascular disease, indeed the ejection fraction of the right ventricle, it's important. In patients with the normal right ventricular ejection fraction, and the limits of normality I wanted to remember is lower than the left counterpart. So the lower limit is 45%. So patients who have less than 45% ejection fraction of the right ventricle is a significant decrease in survival compared with patients with the preserved ejection fraction. And when we compare the predictive accuracy of right ventricular ejection fraction with the conventional parameters of right ventricular function like TAPS and fractional area change, we have seen that the ejection fraction is the best predictor. This was confirmed also by a similar study performed in Japan by the group of Masaki Takeuchi and co-workers, showing once again that the right ventricular ejection fraction in the general population of patients coming to the echo lab for an echo is a powerful and independent predictor of cardiac death and major adverse cardiac events. Elena Surkova went further in another study. She wanted to look at the relative prognostic value of left ventricular and right ventricular ejection fraction. Almost 400 patients that were divided in 4 groups according to 3D ejection fraction of the left and the right ventricle. Group 1 were the patient with the normal left and right ventricular ejection fraction. Group 2 with the reduced left ventricular ejection fraction with the preserved right ventricular ejection fraction. Group 3, the reverse, normal left and reducing the right ventricular ejection fraction. And group 4, where both ventricles were dysfunction. Patients were followed for almost 4 years to look at the all-cause mortality and cardiac mortality. And as you can see, patients with the green line that are those with the preserved left ventricular ejection fraction and reduced right ventricular ejection fraction have a much worse prognosis than those with the left ventricular dysfunction, with that are the red one, and of course of the normal. Of course, when both the ventricles are dysfunctioning, the prognosis is the worst of all. So this is a strong evidence of the importance of measuring the right ventricular ejection fraction in your patients. Recently, we went further, not just normal or abnormal function of the right ventricle, but we performed a cooperative study with our Japanese colleagues. We developed the threshold values to identify normal ejection fraction, more than 45%, mildly reduced the right ventricular ejection fraction between 40 and 45%, moderately reduced between 30 and 40, and severely reduced below than 30. And then we asked our Japanese colleagues to test those cutoff in a validation population that was completely different. And they confirmed the ability of those cutoff to clearly differentiate our patients, both for the endpoint of cardiac mortality and of major adverse cardiac events, that is a composite endpoint of cardiac death, non-fatal myocardial infarction, ventricular fibrillation, and rehospitalization for heart failure. So all this data moved the writing committee of the cardiac chamber quantification or recommendation to recommend the 3D echo for the measurements of the right ventricular volumes and the ejection fraction. I wanted to finish just to remind you that it's not only global function, but we can also use the 3D echo, and particularly the multi-slice that provide a detailed analysis of the different regions of the right ventricle, from the tricuspid valve to the apex, to look at the regional wall motion. And when we started to do that systematically, particularly in patients with acute inferior myocardial infarction, we have seen that the involvement of the right ventricle is much more frequent than thought before. So just to conclude, I wanted to share a few comments. The first one is that 3D echocardiography is the only echo technique that allows a reliable measurement of right ventricular volumes and ejection fraction. Those measurements are accurate if we have a decent acoustic window when compared to CMR. Nowadays, we have the reference values for right ventricular volumes and ejection fraction that allows us to differentiate patients with normal or abnormal right ventricle, and also to graduate the extent of the abnormality in mild, moderate, or severe dysfunction, as we usually do for the left ventricle. And then I would like to conclude with the statement that we have enough evidence now that the right ventricular ejection fraction measured by 3D echocardiography is an independent predictor of outcome in various cardiac conditions. So before starting answering your questions, let me, it's my last presentation, so let me thank Krasimira and all of you for this kind invitation and the opportunity to share with you some of our experience with the 3D echo.
Thank Thank you so much, Professor Badano, for the very interesting presentation today. We are really on the end because we have only one practical session now, and I would like to thank you once again for your cooperation. That was actually in the last moment. Thank you so much. And колеги, имате ли някакви въпроси към професор Бадано? There is no question, but I would like to invite you from today that the next soft echo days will be on the topic valvular disease. So I will be very happy to meet you here face to face.
That would be really nice to start again to be in presence and to be able to share also sometimes together in addition to scientific sessions. I will hope for the best. Thank you, Krasimira.
Thank you.
Ciao.
Thank you. See you soon. Bye.
Yes. Ciao.
Така, колеги, ние продължаваме практически от залата. Ще анализираме, имаме време, 30 минути да анализираме дясна камера и трикуспидална клапа. Така, образ номер волонтер 2. И образът, който ви предлагам да анализираме е 31. За да хванете по-добър образ, тъй като за анализа на дясната камера, трикуспидалната клапа, вие трябва да виждате изцяло свободната стена във всички тези 12 равнини, които в момента ние сме позиционирали. Можете да използвате или този образ, който също ни показва, че дясната камера и трикуспидалната клапа са face разположени срещу нас, с насоченост позициониране на сондата в дясно. Така, 31 образ. Отново отиваме в измервания. И в дясно в менюто клапа. For Auto TV Tricuspid Valve Quantification. Това, което изисква от нас софтуер е съответно да центрираме трикуспидалната клапа във всичките тези равнини, както е посочено във всеки монитор, чрез ротиране съответно. Така. И както бяхме по същия начин за митралната клапа, Set Landmarks. Това, което ни изисква софтуера, да позиционираме предното платно, задно, свободната стена, септум и кооптацията на трикуспидалната клапа. Това е един образ, който е на една нормална трикуспидална клапа. Можем да преминем през различните фреймове, за да сме сигурни, че това, което сме направили, отговаря именно на този профайл, който има самата клапа. Отново преминаваме през фреймовете. И където има нужда, чисто просто коригираме ръчно, за да сме екзактни. Когато ориентирате клапата, виждате, че има различни маркери, които са съответно в зелен, в оранжев, жълт и в розов цвят, което означава, че ние, когато си ориентираме клапата, можем да я видим в тази посока. От тази страна е септума съответно, където е жълто. Предното платно, свободната стена и задното платно. Това е реалната ориентация на самата клапа, което значително добре изглежда. И резултатите, които можем да получим съответно, Annulus на трикуспидалната клапа, диаметрите от 2 и от 4 кухини, коптация, тентинг на клапата, също клапният анулус като обиколка, като диаметър, отстоянието ми, съответно индекс на сферичност на клапата, това, което измерваме като тапсе или екскурзия, excursion, това е тапсе, също и допълнителна информация по отношение на платната. Смятам, че всички се убедихте, че този софтуер е значително лесен за работа и в същото време ни дава доста много информация, която можем да получим при нашите пациенти. Пак на този същия пациент ще извикаме образ номер 30 и ще анализираме в момента дясната камера. Отиваме отново на замервания, само че тук вече не сме на клапа, сме на волюм. И виждате къде е 4D Auto Right Ventricle Quantification. Работим по същия начин, като даваме центриране на трикуспидалната клапа. Съответните равнини. Просто това, което имате в ъгълчетата на всеки образ, така трябва вие да се ориентирате къде да поставите съответно осите и да разположите структурите на дясната камера и трикуспидалната клапа. Така, след landmarks, свободна стена на свързване към трикуспидалната клапа, септум на ниво трикуспидална клапа и връх на дясна камера. Въпросът, който е по късата ос, изисква от нас да позиционираме задна, предна стена и отново свободна стена. Ако сме работили коректно, софтуерът сам приема всичко, което сме направили. Ако ние не сме съгласни с някои от очертанията, можем да ги коригираме. Не искам да ви смущава, че някой път очертанията, които получавате от някои от равнините, нямат нищо общо с това, което виждате. Чисто и просто по време на движение не всяка част може да се добре позиционира. Даваме като резултати. И тази синя структура, която получихме като една реконструкция на самата трикуспидална клапа. Можем да имаме съответно и всичките систолни и диастолни обеми. Това, което получаваме е като фракция на скъсяване, фракция на изтласкване на дясната камера, която е само възможна от триизмерната ехокардиография. ТАПС е като резултат. И можем да се опитаме отново още веднъж да повторим. Номер 31. Като за оценка на трикуспидална клапа, на дясна камера, извинявам се. Центрираме, ориентираме. Свободната стена, септума, апекс, задна, предна и свободна стена. За тези, които са приключили с този пациент, аз ще отида на пациент номер 10, волонтер номер 10. Тук също имаме трикоспидална клапа, добре визуализирана и дясна камера. Образ номер 13. Датата е 18 май. Замерване, обеми, дясна камера. И съответно позиционираме с обърната стена септума, апекса, задна, предна. Резултати, които получихме, значително добра функция на камерата, систола в диастола като контрактилност. Това, колеги, което не показахме, е как е оценката на лявото предсърдие. Пак на този пациент, номер 7 като образ, е по-скоро номер 7, дайте. Отиваме отново на обеми. Това, което е 4D Auto LAQ. Седми образ. 10. Центрираме митралната клапа като център и ориентираме лявата камера. Тук съответно имате друг хиден срез, който също трябва да бъде ориентиран. И трикохинен срез, в който да се ориентира митралната клапа. Необходимо е много малко да местите образа, защото софтуера почти автоматично ориентира. Вие само трябва да нагласите митралната клапа и върха на лявата камера. Смятаме, че сме приключили във всичките тези образи. Можем да дадем ревю. Това, което получихме, е бордирането, съответно по време на диастола, крайната систола, ejection. И можем да дадем резултатите. Това получихме като един обем на лявото предсърдие от триизмерният образ, заедно с включително фракция на изтласкване, диаметри и обеми, заедно с стрейна, който е в тази позиция. Циркумферентен стрейн, заедно с радиален стрейн и лонгитудинален стрейн на лявото предсърдие в различните фази. Какво желаете, колеги, друго да покажем? Лява камера. Добре, лява камера от триизмерна ехокардиография. Този пациент също образ номер 10. Добро изображаване на всички стени, които са на лявата камера. Виждате, работим на достатъчно висок фрейм, около 37. Именно за да се получи стрейна на лявата камера, трябва да бъдете на достатъчно висок фрейм, над 25. Номер 10 е образа. 10. Отново в замерването отиваме по същия начин в обеми. Избираме се автоматичен 4 лява камера quantification софтуер, който е това, което изисква от нас, съответно да преориентираме с малка корекция кухините на лявата камера, така че митралната клапа да бъде в базата, върха да се вижда достатъчно добре във всичките сечения, които имаме. И съответно започваме да маркираме. От този образ, който смятаме, че сме най-коректни в него, база, апекс. Ако нещо не сме съгласни с тези очертания, може винаги да коригираме по късата ос. След това сме на систолен обем, пак по същия начин база, апекс и отчитане на вейформа. Виждате, фракцията е 50%. От тук нататък машината сама вече обработва всички образи, левокамерна маса и стрейновете, които получаваме при този пациент. Съвсем екзактно сме работили в този случай. Виждате, че крайната систолна маса и крайната диастолна маса е 120 грама, което показва, че нямаме голямо разминаване в резултатите. Не може, масата е една и съща, както по време на систола, така и на диастола. И винаги трябва да се отчита това дали има някаква грешка. 4 стрейн резултати. От тук нататък така. Глобален лонгитудинален стрейн е минус 16. Циркумферентният стрейн е минус 14. Зоната на стрейна минус 27%. Радиалният стрейн при мен е 41%. Ротацията на камерата е в градуси 1,3 и торзията е в градус към сантиметри 0,1%. Това, което можем да направим, е допълнителна оценка и на лявото предсърдие като функция и стрейн от двуразмерната ехокардиография. Пак при същия този пациент има достатъчно образи, които можем да анализираме. Номер 15. Съответно в Q-анализис 2D стрейн. Извинявам се, не от тук. Measure. Идваме на AFI, където автоматично ще направим автоматично изчисляване на стрейна на лявото предсърдие. Базално, септално, базално, латерално и таван на лявото предсърдие. Това е стрейна, който получихме обем максимален в 4 кухини. И следващият образ, който ще анализираме за двукухинен е номер 16. Двукухинен. Долна стена, предна стена и таван на предсърдието. Сравнените резултати са един стрейн, който е от 39% глобален лонгитудинален, близко до нормата. Знаете, че над 40% е положителен резултат при анализа на лявото предсърдие. Колеги, нещо, което да е останало неизяснено, да имате въпроси. Уважаеми колеги, това беше краят на нашата сесия. Аз благодаря на всички от вас, които останаха в тези дни като участници в нашите Софийски дни от 2020 година. Искам да благодаря отново на всички спонсори, които бяха така добри да ни подпомогнат в тези две срещи, които организирахме тази година и да се случат тези събития. Благодаря на всички млади колеги, които от снощи до късно останаха на Candlelight сесията и участваха активно с клиничните случаи. Приканвам ви до година отново да участвате, да бъдете по-активни. Наградите остават пак същите 3 от Гедеон Рихтер, плюс едната награда, която е на името на професор Гартиризи, която се дава от Фондацията по неинвазивна образна диагностика за най-добър презентирал се клиничен случай. Благодаря ви още веднъж. Пожелавам ви да сте здрави най-вече, много късмет, хубаво лято и до нови срещи в Софийските дни по ехокардиография 2022 година, които по традиция се провеждат първата седмица, първият уикенд на месец април. Хубави месеци ви пожелавам и най-вече да сте здрави.